But to emphasize again, the essence of isomerism is the distinction between lateralized bodily arrangement and the situation we see in visceral heterotaxy. So you all know that in the usual situation, the right-sided lung has 3 lobes, is fed by a short bronchus. The left-sided lung has 2 lobes and is fed by a long bronchus. If we look below the diaphragm, again there is evidence of lateralization, the liver in the usual situation being right-sided, stomach and spleen being left-sided, and then within the heart, the pectinated appendage is on the right side, the smooth vestibule on the left side, and we can lump all of that together as being the usual arrangement. And then in a minority of cases, we have the situation in which everything is mirror imaged. So the trilobed lung with its short bronchus is now left-sided, the bilobed lung with its long bronchus is right-sided, the abdominal organs are mirror imaged, as are the atrial appendages, and as we've discussed, we can call that mirror imagery, although I'm sure in most instances you will continue to describe it as situs inversus. We need to distinguish both of these arrangements with the situation that is commonly lumped together as visceral heterotaxy. Now, I believe very strongly that it is necessary to divide visceral heterotaxy into its 2 subsets. Because if, for example, we concentrate only on pulmonary and bronchial anatomy, there is no question that in one subset of visceral heterotaxy, both of the bronchuses are short and both of the lungs have 3 lobes. If we look below the diaphragm, in this subset of visceral heterotaxy, the liver is most usually midline, and in many instances there is malrotation of the gut. If we look within the heart, as we will see, the essence of this subset of visceral heterotaxy is that both of the appendages are pectinated, but in many places this arrangement is still called asplenia, and there's no question, but in the majority of cases the spleen will indeed be absent. But this is one subset of visceral heterotaxy. And the other subset, if we concentrate our attention first on the lungs and the bronchial tree, now we have evidence of left isomerism. Both of the bronchuses are long. Each of the lungs has 2 lobes. And then if we look below the diaphragm, again we find a midline liver. Now we see multiple spleens along with malrotation of the gut, but within the heart, both of the appendages have the morphology of the normal left atrial appendage. And many people will call this polysplenia. It is my belief that the analysis of this form of cardiac disease is the atrial appendages. And I should emphasize at this point that in the setting of visceral heterotaxy, it is only the appendages within the heart that are truly isomeric. So it is a mistake to talk about atrial isomerism. We never have atrial isomerism in the setting of, for example, left atrial isomerism, where we would expect 8 pulmonary veins. But on the contrary, in one of the subsets of visceral heterotaxy, always there are 2 left atrial appendages. So we need to be careful when we talk about isomerism only to specify isomerism of the atrial appendages. And it's equally important to emphasize that we base this distinction not on the shape of the appendages, but on the extent of the pectinate muscles. Whenever we see isomerism of the atrial appendages, however, we anticipate all the anomalous venous connections that we've just been discussing. Some of these anomalous venous connections exist with both forms of isomerism, particularly bilateral connection of the superior caval veins. But others serve to stratify the 2 forms of heterotaxy, which I like to consider in terms of right isomerism and left isomerism. So when we have isomerism of the right atrial appendages, always, in my experience, there has been absence of the coronary sinus, and because we have 2 right atrial appendages, always there is totally anomalous pulmonary venous connection, albeit that in a good proportion of cases those anomalously connected pulmonary veins come back to the heart itself rather than to a systemic venous tributary. On the other hand, when we look at the other subset of heterotaxy, that characterized by isomerism of morphologically left-sided structures, then the features we anticipate in terms of venous connections, interruption of the inferior cable vein. Although, as you've always also seen, that can exist with usual atrial arrangement. Now let me emphasize again that we distinguish the arrangement of the appendages not on their shape, but on the extent of the pectinate muscles, so that when the pectinate muscles encircle the vestibule of either atrioventricular junction, the appendage is morphologically right, whereas when we have the pectinate muscles confined within a tubular appendage and a smooth vestibule, is morphologically left. And then when you look at situations like this with a common atrioventricular junction, there can be no question that the pectinate muscles extend round this junction on both sides, and I would defy anybody to tell me that this is other than isomerism of the morphologically right atrial appendages. The situation is more problematic in the other subset because, as Andrew has already told you, on occasions the pectinate muscles spill out of the tubular appendages, but when looked at carefully, we see that the posterior part of the right-sided vestibule is smooth, as is the most posterior part of the left-sided vestibule, and this is the situation which we describe as isomerism of the left appendages. So I believe we can stratify visceral heterotaxy into right isomerism and left isomerism, and in the setting of right isomerism we would expect bilateral superior cable veins. Probably in over half the instances we would find that arrangement. Always the coronary sinus will be absent, and because of that the coronary veins drain directly to the atrial chambers. And always there will be totally anomalous pulmonary venous connection, albeit that this anomalous connection is to the systemic venous tributaries in autopsy series in only about half of the cases. But when it does come back directly to the heart, usually it is to a midline confluence. But here is a situation where unequivocally we are dealing with a morphologically right appendage, not only in terms of its shape, but also the extent of these pectinate muscles running round the right atrioventricular junction. You see that the coronary sinus is absent, but here in the posterior wall of the right atrium we have drainage of all pulmonary veins. Here is a more typical situation of cardiac connection in the setting of isomerism of the right atrial appendages. Unequivocally in this instance, both pectinate muscles extending to the crux, again with absence of the coronary sinus, but now the pulmonary veins are squeezed together into a small midline confluence with fibrous walls that open the atrial roof. So when the coronary sinus is absent, how does the coronary venous blood get back into the heart? Well, obviously, it must drain directly. And this can do either by a direct channel, through a small crooked connection in the atrioventricular groove, trying to produce a coronary sinus, but in many instances by veins that cross the atrioventricular junction at some distance from the usual site of anticipated drainage. And here is such a distant connection seen up the diaphragmatic surface of the cardiac mass in this instance of isomerism, and you see this large venous channel which crosses the atrioventricular junction and continues within the wall of the right atrium, draining to the pulmonary venous sinus. In left isomerism, again we can expect bilateral superior cable veins, but in many instances now one or other of these will drain via a coronary sinus. So in left isomerism, since the coronary sinus is a morphologically left structure, we can expect it to be present. But sometimes it's absent, and then as in right isomerism, the coronary veins will drain directly. The pulmonary veins also can drain back to the heart, since the pulmonary veins are also morphologically left, and oftentimes they are symmetric, two draining to each side. The expected anomaly in this instance is interruption of the inferior cable vein, either with direct drainage of the hepatic veins or for diaphragmatic confluence. So Andrew has shown you beautifully this example where we have, in a fetal case, isomerism of the left appendages, and then this large venous channel running up the left paravertebral gutter and the superior cable vein. But be aware, we can also have bilateral azygos return, in this instance with left isomerism and right-sided multiple spleens. So when we describe the heart in visceral heterotaxy, we should remember that it is only the appendages that are truly isomeric, but certainly there is total justification now for describing isomerism of the atrial appendages. We can identify those appendages as being right or left according to the extent of the pectinate muscles. It is the venous connections that permit us to stratify these patients into the two subsets of right and left isomerism. In left isomerism, we find azygos continuation. In right isomerism, we find totally anomalous pulmonary venous connection along with absence of the coronary sinus.